Welcome to everybody and good morning. This is our start of the school year, as has been mentioned. Welcome to our GI fellowship applicants. This is the Jerry Waye Endoscopy Conference. So just by way of a little background, Jerry Waye, if you don't know who he is, you soon will learn just spending the day here. Jerry is one of the forefathers of colonoscopy and particularly polypectomy as a way of colon cancer prevention. And he has been a stalwart here at Sinai for about 50 years, and he recently retired. He started this video case conference over 30 years ago, and every Friday morning for the past several decades, he would bring interesting cases to show GI and surgical colleagues, and it's just evolved over the years. And now it's one of our favorite events during the week. We have our consult fellows, our advanced endoscopy fellows, surgeons, pathologists, radiologists bring interesting cases for education and discussion and debate. Excuse me. Excuse me. And so we're excited to kick things off. So I will turn it over to Yu Ying and Zoe. I'll let you guys start the presentation. I think everyone's connected, and as you all know, feel free to chime in with comments and questions.
Hi, everyone. I hope you guys can see my screen. I'm Yu Ying. I'm one of the first-year fellows, and I'm excited to share a case that I saw on consults last week. You'll have to forgive me just because the video unfortunately didn't save in Provation, but I do have some good images. So our case begins with a 56-year-old female. She has a history of familial adenomatous polyposis that is post total proctocolectomy with an ileostomy back in 2012, who presented with fatigue and shortness of breath for 1 week. She actually had an endoscopy back in March of 2018 that demonstrated multiple gastric polyps with evidence of prior bleeding, and at that time, a normal duodenum. She had an ileoscopy that was essentially normal and showed 1 polyp at her stoma site. On review of systems and interview with the patient, she just reports noting occasionally bright red blood in her ostomy bag, but that the color of the output and the amount of output was still the same, and it was brown. Her hemoglobin on arrival was 6.3 from a baseline in the 10s. So after appropriate transfusion, we took her to the endo suite and performed an upper endoscopy and ileoscopy. So here are some of the images that we captured during our upper endoscopy. You can see that the entire stomach, including the proximal stomach, body, fundus, and antral area, were covered with these like innumerable friable polyps. They ranged in size from 5 millimeters to greater than 3.5 centimeters. In addition to these individual polyps, you can see that there are essentially these like mounds of polyps. It's really hard to actually distinguish the polyps individually, and one might say they resemble a carpet. We also saw a broad-based polyp in the duodenum, which was visualized at 10 o'clock. So through this endoscopy, we established that the likely etiology of her ongoing bleeding and anemia were from these multiple gastric polyps, just because some of them were spontaneously bleeding and oozing. But the next step in sort of her management clinical course was, what were these polyps? What should be done about them? Because they were spontaneously oozing and they were so extensive, we didn't end up doing any polypectomies. So we took biopsies from the gastric and duodenal polyps, and they actually came back indefinite for dysplasia, and we'll talk a little bit more about what that means. And our patient ended up being transfused a total of 4 units of packed red blood cells with resolution of her shortness of breath and fatigue, and she was discharged home. So I thought this would be a good time to review gastric polyps specifically in FAP, just because there is a spectrum of the type of gastric polyps we see and required different management. So the ASGE actually just very recently in May of this year came out with new guidelines on the role of endoscopy in familial adenomatous polyposis syndromes. As a review, FAP is a complex entity. It includes FAP itself, attenuated FAP, and MUTYH associated polyposis. Patients with FAP are at risk for colorectal cancer, but also carry a risk for extracolonic cancer as well, including cancers in the duodenum, thyroid, hepatoblastoma, desmoid tumors, and stomach cancer, you'll notice, is not actually all that common. Funded gland polyps are the most common types of gastric polyps that you'll see in patients with FAP. They have a prevalence of up to 90%. Dysplasia can develop in funded gland polyps in patients with FAP, unlike the sporadic funded gland polyps that you see associated with PPI use. In one case series, they actually found that dysplasia was in up to 42% of patients, and that it was more likely with larger polyps greater than 1 centimeter, like in our patient, and increased severity of duodenal polyposis. Gastric adenomas are less common than in patients with FAP in the Western countries compared to Eastern countries. The prevalence in the US and Europe is about 10%, whereas in Asia, it's about 36 to 50%, just because there is a higher incidence of gastric cancer in that region of the world. Adenomas can occur anywhere, but typically they occur more commonly in the antrum and appear sessile, and they look kind of subtle with a villiform red appearance, and are sometimes, although if they occur in the fundus, are difficult to differentiate from funded gland polyps. And lastly, gastric adenocarcinoma. They also can occur anywhere in the stomach, and they can be multicentric and metachronous. It is thought to be fairly rare in the Western population, but a recent case series demonstrated that gastric adenocarcinoma in FAP patients in the US has actually increased with an overall incidence of 1.3%. And interestingly, these authors in that same case series did intervals, sort of time to interval of diagnosis, and basically the average time from initial colectomy to the diagnosis of gastric cancer was an average of 23 years. So what do the ASGE recommend? They recommend 3 to 6 month interval surveillance EGD with aggressive polyp sampling and endoscopic debulking, especially these gastric polyposis mounds that we saw in our patient, because they found more stage 1 cancers using these protocols. They recommend evaluation of all polyps, including funded gland polyps, with random biopsy sampling and complete resection of polyps greater than 1 centimeter. Because of the high risk of adenomas and antral polyps, they recommend that all antral polyps should be removed regardless of size. And they also listed some endoscopic risk factors that are associated with malignancy, including carpeted funded gland polyps and mounds of gastric polyps that are in the fundus and body. And lastly, for patients who have funded gland polyps and adenomas that harbor advanced histologic features, or those who fail endoscopic management in terms of debulking, they recommend evaluation with an experienced surgeon. Recently, a new endoscopic entity has been identified that is potentially worrisome in patients with FAP. This is the white mucosal patch. It is a well-demarcated area of mucosa with actually normal mucosal and vascular patterns that is surrounded by a carpet of funded gland polyps. The whitish area that you see here is easily distinguishable from the reddish appearance of the polyps that are the funded gland polyps in the stomach, especially when chromal endoscopy is used. The white mucosal patch lesion is usually a bit elevated. It's usually a Paris classification 0 to 2A. And I found this case review in GIE that was published back in 2018 that demonstrated that patients with white mucosal patches were more likely than patients without non-white mucosal patches to have high-risk endoscopic features, the carpeting of proximal polyposis that we talked about, and these polypoid mounds. Table 1 here demonstrates the higher prevalence of high-risk pathologic features, both within the white mucosal patch and outside of the white mucosal patch. And what the authors point out most alarmingly is that 2 of the 14 patients with white mucosal patches had proximal gastric cancer with a prevalence of 14%, which is much higher than the overall prevalence of 1% in our overall US population. So the authors postulate that if you see these white mucosal patches, specifically in the proximal stomach of a FAP patient, it's a feature that can be potentially associated with gastric cancer. So just some take-home points. Gastric polyps in FAP include funded gland polyps, which are the most common, up to 50% of which can be associated with dysplasia. Adenomas and gastric adenocarcinomas are much rarer. The ASGE recommends 3 to 6 month EGD surveillance for biopsy and debulking of all polyps greater than 1 centimeter. Some of the worrisome endoscopic features that are associated with malignancy, including carpeted funded gland polyps, densely concentrated mounds of gastric polyps, white mucosal patches, and lastly, and this is what happened with our patient, is a surgery evaluation for patients who harbor either histologic features that are considered high risk or fail endoscopic management in terms of debulking or that it's so extensive that it's impossible to survey. All right, that's it. Thank you.
Thank you so much. That was fantastic. So much that we can talk about here. It's a little interesting, and I'm going to ask Steve Itzkowitz to comment in a second. I'm very surprised at those ASGE recommendations. They seem quite aggressive. I think in our practice here, we typically leave gastric polyps alone, and it's usually more the duodenal adenomas that are the big issue that we're dealing with in this patient population. And I can probably count on one hand how many times I've seen a gastric cancer in an FAP patient. But Steve, we'd love your input on this. And should we be more aggressive in our endoscopic surveillance and management of these patients?
Yeah, thanks, Chris. Let me start by first acknowledging the wonderful virtual background that Zoe put up. I think it's really, it's so creative and so clever. I guess the pink colon reflects the fact that all of our fellows are women this year. I'm not sure. At any rate.
Mucosa.
It's mucosa, got it, okay. And also, and Yu Ying, you did an incredible job. I tell you, for the first talk of the year, it was really perfect. And you highlighted all the really important topic issues. Chris is right. I think these recommendations are very aggressive. It takes many, many, many years for people who have all of these gastric polyps for them to ever get gastric cancer. And somehow surveying them every 3 to 6 months seems kind of overkill. You know, it's really easy to write these guidelines, but in reality, you look at that stomach, you can't identify polyps that are 1 centimeter or 1.5 centimeters, or it's just carpeting. And it's very, very treacherous to manage these patients. That white mucosal patch sign was really a breakthrough a couple of years ago. If you see that, that's an area where you may be more likely to find high-grade dysplasia. So you want to target your biopsies or polypectomies there, but most of the time you don't even see that. A question I have about this case is that you described, Yu Ying, that there were polyps in the antrum. Now, the antrum is almost always spared of polyps in FAP patients. If you see a polyp in the antrum, it's usually single, and it's usually an adenoma, not a funded gland polyp, but an adenoma. And the pathology report said hyperplastic inflammatory polyps. It didn't say funded gland polyps. And I'm wondering whether the diagnosis on this patient is juvenile polyposis altogether. Because with juvenile polyposis, you can find polyps throughout the stomach, not just in the proximal stomach like you see with FAP. So has this patient been genetically tested? Does she have a germline APC mutation? Do we know that?
Actually, she came to Sinai with the diagnosis of FAP, so I don't believe she was germline tested when I went back into the charts.
The first thing I would do, because the other thing is juvenile polyposis, if that's what this is, those polyps are very friable, like you showed, and they bleed. And these people with juvenile polyposis walk around all the time with iron deficiency anemia because those polyps just ooze blood all the time. FAP patients, even with the carpeting in the proximal stomach, the adenomas don't bleed as much, not the adenomas, the fundus gland polyps don't bleed as much as the juvenile polyps. So the first thing we have to do is confirm the diagnosis here. She needs genetic testing if she hasn't had it already, because this might well be juvenile polyposis syndrome, which changes things. So that's one thing. I don't know, I don't see any of the pathologists on the line.
Oh, I think Noam is on.
Oh, Noam is on.
Yeah.
Noam, I wonder if you can comment on the distribution of polyps in the stomach, comparing juvenile polyposis and FAP.
You're muted, Noam. Can you unmute?
Maybe not.
Maybe didn't hear. Okay, at any rate, those are my comments. And the last thing I'll leave you with, and Yu Ying highlighted this, although gastric adenocarcinoma is really a dreaded consequence of FAP, it's still extremely rare. And as scary as these stomachs look, we have to be careful not to overreact, because most of these people, as Yu Ying said, have already had their colectomy. And if you then consider taking out their stomach and doing really what becomes very often a total gastrectomy, their quality of life is horrible. So it's a real tricky decision to make, to do anything other than just sort of endoscopic surveillance on these stomachs.
So we had a case, Steve, I think you were involved. It was a patient, FAP patient, who already had his colectomy. We saw him for duodenal polyposis, and he had a very high-risk lesion that was not endoscopically resectable. And almost just sort of incidentally on the way out, I saw a small little area at the cardia GE junction, which, you know, looked like esophagitis. I took a biopsy and it came back as gastric cancer. And Nikhil was able to do so he needed a Whipple for his duodenum. He already had a colectomy. And based on the location of this gastric cancer, he would have needed a total gastrectomy as well. I don't know if we ever presented the case, but Nikhil was able to do an ESD, resect the proximal gastric lesion, and then he went on to have his Whipple, and at least he was able to save his stomach for the time being. So, I mean, it's really just amazing.
That was an amazing case. It was amazing that you saw that little bump and that it turned out to be cancer and that it was locally resectable. That it's reportable. But that's really a great win. I don't know if Noam, do you hear us? All right, maybe we can move on.
All right, great case. Thank you again, and more to follow.
Sorry, I was muted.
Oh, yeah.
Steve? I was muted.
You have a 1-minute commentary window.
I have no comment. I don't know which case you're talking about, but it sounds amazing.
No, a quick question to you, Noam. In the stomach of an FAP patient versus the stomach of a juvenile polyposis patient,
Wow.
Is the antrum spared? The antrum is almost always spared in FAP, but what does the antrum look like in juvenile polyposis syndrome?
I don't know that there's any particular distribution, but I'd have to look that up. It's not like we see it very often, and it's really just a handful of cases that we've seen.
And
but I'm not aware it has the same kind of proximal distribution.
And if you report a gastric polyp as being hyperplastic or inflammatory, that's different from fundus gland polyp, is it not?
Oh yeah,
so
completely different.
Yeah, so you see the histology here is taking us down the road of juvenile polyposis, not FAP. So it's really important to know your histology.
It would look more like an inflammatory type of polyp, and usually only if we know the patient's history can we tell you, well, that looks identical to a juvenile polyp.
Yeah. Okay.
So I'm going back to being muted.
Thank you.
Okay, Zoe, Miss Pink Colon, you are up.
All right, Yu-Ying, do you mind sharing your screen again? Thank you so much. So good morning, everybody. I'm Zoe. I am one of the third-year fellows and one of the chief fellows. I'll talk to you all this morning with Yakira. I am going to talk about a case that we actually did a few weeks ago when I was covering the inpatient service. So next slide. So this is a 65-year-old gentleman. This is actually Jamila's patient, but I don't think she's here this morning. I think she might be on vacation. This is a 65-year-old gentleman. He has a history of end-stage renal disease from hypertension and diabetes. He had a deceased donor kidney transplant in 2015, for which he's been on belatacept, Cellcept, and prednisone, low-dose prednisone, only about 5 a day. Hypertension, diabetes, as I mentioned, BPH, who came to Sinai after being hospitalized at another hospital for several weeks with fever, anorexia, and incidental weight loss. He had no GI symptoms, no abdominal pain, diarrhea, nausea, vomiting, black or bloody stool. And when he got here, transplant ID was consulted, renal was consulted. He had a very extensive infectious workup, which was only positive for JC viremia and HHV8 viremia, both pretty low grade and both which were thought to reflect excessive immunosuppression rather than necessarily a source of infection per the ID consultants, and were of unclear clinical significance. He had a bone marrow biopsy. It showed some immature forms. It wasn't sort of a slam dunk. They thought it might be consistent with immunosuppression versus MDS and planned to repeat it later. And the got several imaging studies, including a CT, abdomen, pelvis, and an MRI brain. The MRI, because of the JC virus, nothing was clear, and he continued to spike fevers into the 102, 103 range. So GI was consulted to do an endoscopy to rule out any occult malignancy or opportunistic infection. And when I came, I was actually just scoping, and I was kind of surprised to hear this because I had never previously scoped just for fever of unknown origin. Next slide. So this is the video. The quality of the video is not excellent, but basically what you can see is when we went into the stomach, we saw multiple sort of erythematous, almost bilaceous lesions that were extremely friable and distributed really throughout the entire stomach. There were not dense patches or extremely large versions of them, but they were sort of certainly abnormal and made us worried about particular opportunistic infections we can talk about in a moment. So if you can go to the next slide, actually the photos are significantly better than the video. You can see these sort of polypoid, very friable lesions, red, but also actually on the actual scope appeared a little bit also more violent in color. So we took extensive samples. And if you go to the next images, the pathology was actually consistent with Kaposi sarcoma, which is what we had postulated when we were doing the endoscopy. And this was not surprising to us in the sense that he had this HHV8 viremia and also was immunosuppressed, but he was immunosuppressed in the setting of a renal transplant, which is actually not a common scenario for developing Kaposi sarcoma. We really think about it much more in the context of immunosuppression in the setting of HIV. So from a clinical course perspective, they modified his immunotherapy throughout actually his hospitalization. He ended up being changed to sirolimus and continued his low-dose prednisone. He was discharged with a plan to follow up with solid oncology to discuss management of KS, and he hasn't had that appointment yet. So I thought this would be a good opportunity to discuss Kaposi sarcoma in the GI tract. And as I mentioned, there's really not a lot of data on cases in immunosuppression from medication in the setting of post-transplant, for example. Most of the cases and studies have been performed in the context of HIV. And actually, we're writing this case up because it was so interesting and surprising. So I'm going to review a paper that was published in PLOS One in 2012 that looked at clinical predictive factors in the diagnosis of gastrointestinal Kaposi sarcoma and endoscopic severity. Because, for example, in this case, the patient had no cutaneous lesions and he had no GI symptoms. So it was really only in the context of doing a really thorough FUO workup that we ended up even doing an endoscopy. So The background and objectives. So just to give a little bit of background on Kaposi sarcoma, it's a rare malignancy. It's associated with HHV8. It involves the lymphatics and blood vessels. Most commonly presents as these small violaceous lesions on the skin, but can have visceral involvement, including the GI tract. The higher risk is in immunosuppressants, and the prevalence is particularly high in HIV patients. And patients with KS of the GI tract might have no GI symptoms or skin lesions. So the objective of this study was to identify clinical predictors of severe KS on endoscopy in patients with and without GI symptoms. So this is a retrospective study of over 1,000 patients with HIV who had undergone endoscopy at a single major medical center in Tokyo between 2003 and 2009. The indications for endoscopy: CD4 count a week before the scope, HIV viral load within a month of the scope, history of treatment with antiretrovirals, and HIV infection route were all reviewed. And abnormal lesions seen on upper or lower endoscopy were biopsied, and they were the severity was determined based on the size of the lesion, the alteration, and the number of overall lesions. And they defined gastrointestinal KS as the presence of proliferating spindle cells on H&E staining. So this is actually lesions from their paper. I just wanted to give an example of sort of the range of different endoscopic findings that you can see in KS. I've actually seen endoscopic KS before, or gastrointestinal KS before. It looks more like or in my prior experience, it looked more like image C. And if you click one more, Yu-Ying, I just put up a picture of our patient to compare the findings, just so you can see there really is a very wide range of endoscopic appearances. So if you have any suspicion, it's extremely important to perform multiple biopsies so that you can get a good tissue sample. Next slide. So the results: the median age was 44. Almost all of the patients were male. Most patients had a CD4 count of 239 and a viral load that was less than assay, and the majority had received antiretroviral therapy. Only 33 patients of this over 1,000 patient cohort actually were diagnosed with gastrointestinal KS. 78.8% of them had no GI symptoms at all, and only 24.2% had cutaneous lesions. So really important to have a high suspicion. In their univariate analysis, the only predictive factors that were associated with gastrointestinal KS were patients who had gotten HIV through MSM transmission, patients with very low CD4 counts or HIV viral loads, patients who had never had antiretroviral therapy and as sort of a proxy for being particularly immunosuppressed, and those who had cutaneous KS. And then when they performed the multivariate analyses, cutaneous KS was the only independent clinical factor related to GI KS in patients with and without symptoms. And in patients who had no skin lesions, MSM transmission and a low CD4 were the only independent clinical predictors. I made this little pie chart just to give you a sense, because they did both upper and lower endoscopy, where the larger proportion of patients had their lesions. And really stomach and duodenum were the largest range of patients, but patients did have lesions throughout the entire GI tract, including esophagus, TI, colon, and rectum. So this is just to give a sense. This is a large table. I actually hate saying this is a table. It's kind of hard to see, but to give you the overall sense. But basically, the most important findings is that bulky tumors were associated with very low CD4 counts, and multiple lesions were associated with very high HIV viral loads. And there was no significant difference in the presence of skin lesions in patients who had mild or severe KS on endoscopy. And I think this sort of goes back to the overall point: is the more immunosuppressed you are, the more likely you are to have a more severe endoscopic presentation of KS. So just the big takeaways: most patients who have gastrointestinal KS don't have GI symptoms. They do not have to have cutaneous lesions to have GI involvement. The risk of severe GI KS increases with increasing immunosuppression. And basically, if a patient is immunosuppressed for any reason, not just in the setting of HIV, and systemically ill with an unrevealing workup, you should consider an endoscopic evaluation. And having done this literature review now, I would have said, had we not found anything on the upper endoscopy, it would have been worth doing a colon as well, because these lesions can be anywhere throughout the GI tract. That's it. Thank you, Yu-Ying. You are an incredible PowerPoint helper. I really appreciate it.
Zoe, one question. We know these lesions can be vascular and can bleed easily. Is there any concern or reports of patients having severe bleeding after a biopsy?
I didn't find any, and Dave is shaking his head no, and I would defer to him as the endoscopic expert on this more than I am. But they oozed, but we did not have such significant bleeding. I did this case with Bridgen. there was really not a lot of worry. They oozed less than, for example, when we take biopsies of tumors like in the esophagus or in the stomach that really, really bleed, that I always get worried we should like chemo spray or something like that. But it did not bleed that much. I'd have to do a more extensive literature review about post-biopsy bleeding.
And then I may have missed it. I apologize if I did. Is there any correlation with prognosis? Is if you have GI Kaposis in these immunosuppressed or HIV patients? In other words, are they more likely to have a more disastrous disease course or complications?
It's in HIV patients, the development of KS reflects an extremely immunosuppressed state and is associated with a higher viral load. So I think these patients are overall more systemically ill with more severe courses. There are really not a lot of cases describing KS or GI KS in patients who are on immunosuppression in the setting of other disease courses. Like this was in the setting of being immunosuppressed from a kidney transplant. And so that's why we're actually attempting to publish a case report on this, because it's so, the description of it in the literature has such limited supply. Because it is really interesting. What is his outcome going to be? There's also this question in him about, did he have MDS versus was this just like an abnormal bone marrow transplant because he was on such high levels of immunosuppression? And I wonder sort of what the outcome is. I'm sure we will scope him again. I think he's actually following up with Dr. Mahandru in clinic in a few weeks. I'm sure we'll scope him again once he's received treatment to sort of see what's going on. I'm very interested to see what his course is in terms of fevers and poor PO intake once his immunosuppression has been modified and then once we treat the KS.
Zoe, this is more of a comment than a question. So it's actually very interesting. You alluded to this just now. We don't really understand what the correlates of some of these opportunistic either infections or lesions in the gut is, because the GI tract does get very, very profoundly depleted of CD4 cells very early in the course of HIV infection, within the first 2 or 3 weeks of infection. And yet these opportunistic or inflammatory lesions, they occur much later on in the course of HIV illness when immunosuppression is more profound, and it correlates actually with a systemic loss of CD4 cells below certain thresholds, like below 200, 100, or 50. So what changes in the mucosa at that level? Are there some innate cells that change? Is there a difference in trafficking to the mucosa because the bone marrow is so profoundly suppressed, so you turn off the tap? These are all, I think, questions that even to this day within HIV have been unanswered. And I would just, sort of use this opportunity to just mention to anyone that if you're seeing patients like this, which are rare now, I think consider these sorts of questions that we still don't understand why they're having these advanced lesions in the mucosa, and that would actually be an advance if we were to try to figure out. And there are technologies now to be able to at least attempt to do that. But great case, thank you.
Great.
And I would just point out that if you look carefully at the endoscopic photos that you showed, these violaceous lesions in KS, they have sort of a giraffe skin-like appearance, unlike other little red bumps that you might find in the stomach occasionally. If you look really closely, it looks a little like giraffe skin. So that's another tip-off that it's KS. As someone who really grew up at the beginning of the AIDS epidemic, we would see KS patients 4 or 5 times a week. It was extremely common before we knew enough about what was causing AIDS.
Steve, is that your descriptor or is that an established descriptor?
It's mine, but I haven't published it. Maybe I should.
That was sort of what I was going to say too. That KS we used to see this all the time.
Yeah.
And Chris, to answer your question, the prognosis had to do with the underlying HIV immunosuppression.
All right, thank you so much, Zoe. Fascinating case, great discussion. We have time for one more, it looks like, and we're gonna turn it over to Nick, our advanced endoscopy fellow. Let's see.
All right, thank you. Sorry for the lack of video. I will figure out the technology issues for next week, but I do have a presentation, so I'll share my screen. Okay, So again, my name is Nick Herder. I'm the Advanced Endoscopy Fellow here at Sinai, and I'm going to present a case of Gallstone Illeus. The patient was a 55-year-old male, presented, he has a history of Crohn's disease, status post-colectomy with endoileostomy remotely, also a remote self-inflicted gunshot wound with cognitive impairment, a few other medical comorbidities, coronary artery disease, hypertension, and 2 years ago, he had cholecystitis at an outside hospital and had a cholecystostomy tube that was subsequently removed. He presented initially with hypotension and abdominal pain. In the ED, he was actually hypotensive and febrile and septic, requiring pressors. He was noted to have some abdominal tenderness. On labs, he had a leukocytosis, pretty severe AKI, relatively unremarkable LFTs. On imaging, he had a few findings. So he had dilated loops of bowel. You can see air fluid levels on the left, consistent with an obstruction. He had pneumobilia. You can see in the left image, air in the left intrahepatic ducts. And on the right image, air in the gallbladder. I'm not sure if there's a fancy medical word for that. I would propose this ridiculous word here, pneumocholecystia. And then most dramatically, he had a stone obstructing his ileostomy. So that one kind of is the giveaway. And so he was diagnosed with Gallstone Illeus. Given the location of the stone, since it was so close to the ostomy, rather than proceeding with standard management, which would have been surgery, we elected to take him for endoscopy to see if we could potentially manage this issue a little less invasively. So I have an endoscopy video. Hold on, this video is, okay. So immediately upon entering the ostomy, there was this impacted stone, and you could actually feel it, you could palpate it with your finger. And you can see it is occluding essentially the whole lumen as expected. And we couldn't really, there was no way to get around it with the scope or really pass any devices past it. And so we elected to try to break it up with electrohydraulic lithotripsy, which is the device that you will see in the lower left here. And this is a sort of extensive video of this just because it's so satisfying to see the stone break up with the HL that I left it kind of uncut for a few minutes, and we'll just see this stone progressively explode as I explain how EHL works. But essentially the device has 2 electrodes, and there's a high voltage spark that's produced between the electrodes. It's meant to be used in a fluid medium, so you can see continuous irrigation here with saline. The saline also helps with conductivity between the electrodes. And the spark creates a shock wave in the fluid because the fluid rapidly expands, and the shock wave basically causes mechanical destruction of the stone. And the idea is, it's not perfect technique here, but you're supposed to hold it like just off of the stone and then apply energy, and the shock wave breaks it up. The probe is designed to fit through a cholangioscopy scope, which is a 1.2 millimeter channel. So it's very fragile. As you can see, it's kind of tiny, you know, relative to the stone. So if you hold it up too close, it can, it kind of breaks the probe. And sometimes you have to go through a couple probes if the stone is really large. This one you can see, the stone is fragmenting beautifully. There's pieces flying everywhere. And very soon we will have a big break that will get us through this. I think it's about to happen. So it's going to clear up enough here to get through. And you can see this is the mucosa in the ostomy. As you recall, he had a remote history of this Crohn's diagnosis and wasn't on any therapy. And it became immediately apparent that he had very severe disease recurrent at the ostomy here. And you can see deep ulcerations, inflamed mucosa, and then this area is very tight as well. Just looks sort of like an inflammatory stricture. And this is part of the reason that contributed to the stone getting stuck, because it was just so narrow at the exit. So this is just showing that. And then here is the major piece of the stone. There are little pieces floating all around. And this was still big enough, although it was now free floating in this part of the lumen, it was still big enough to obstruct the exit to the ostomy. So we elected to remove it here with a Roth net. And we burst it from the ostomy here. So it was still tight coming out. And there it is, the culprit. All right.
Very cool.
So he actually did great after that. He had return of ostomy function pretty much the day after, improvement in his leukocytosis and his AKI. And I was so happy with the result. Everything was great. And then he actually got a little worse from a second problem. He started having feculent output from his prior cholecystostomy site. And essentially, he had developed a fistula between the bowel, the gallbladder, and the skin. So it's kind of like an enterocutaneous fistula, and had to go back to the OR for that reason. So he had an ostomy revision given the active Crohn's there, takedown of that enterocutaneous fistula, and a cholecystectomy, which would prevent recurrence of Gallstone Illeus in the future. But then he did great post-operatively. So we'll go through just a couple teaching points.
Nick, I'm just
Gallstone
going
Illeus is pretty rare. Yeah, sure.
I'm just going to interrupt. We have about a minute before we have to wrap
Okay,
up.
1 minute. I won't go nuts about talking about Leo Rigler. Interesting guy. Okay, so the triad is an imaging diagnosis for Gallstone Illeus, pneumobilia, intestinal obstruction, visualized stone. The reason for the pneumobilia is in order for a stone that's large enough to obstruct the lumen to get out of the gallbladder, you essentially have to have a fistula between the gallbladder and the intestine, which results in the pneumobilia. So that's that finding. EHL, we talked about here. We usually use it for difficult to remove bile stones, occasionally pancreatic duct stones. And as I described, it's usually used through cholangioscopy. It has been shown to have good efficacy with about 88% ductal clearance in a large meta-analysis. And it has reduced rates of cholangitis and mortality compared to just stenting alone in the case of recurrent stones or difficult stones that can't be removed by other methods. And that's that.
Outstanding. That looks like fun. It's never gets old when you break up stones or remove big stones.
It was so satisfying.
It's a little weird. I don't know if that was your first EHL case this year, but it's a little odd that it occurred outside of the bile duct. But then again.
True, that wasn't the standard approach.
So Nick, why did you use electric shock rather than mechanical lithotripsy when it was so easily accessible?
So we did. Yes, that is a great question. We thought about, what devices we have available. And then I think the key in that case was that we couldn't really get around it. We didn't even really try too hard, but we would have had to get the mechanical lithotripter basket sort of around the stone. And just because it occluded the entire lumen, I think it would have been challenging technically to use that device. So luckily the EHL doesn't require you to get behind the stone. You just sit right in front of it. So it was really amenable to that therapy.
We also had hoped to pull it out manually, but the stricture at the ostomy site prevented that from happening. So we had to break it up.
And if you look at the data regarding mechanical lithotripsy versus EHL for removal of large stones, EHL or laser lithotripsy wins out every time for shorter procedure times, fewer number of endoscopic sessions if more than one is needed. And it's just technically easier and certainly more fun, but mostly it's more effective.
Love it.